Okay, hello everybody. I hope that you can hear me well. Yeah, it's a pleasure for me to moderate our November Iran PETCAN webinar, and it's great that Evangelia, Antoniou, who's currently working in Germany, is going to present an unusual case of pediatric AML, and it's of course a pleasure to have Michael Dworzak here, who's a worldwide known expert in pediatric AML, and who will also discuss with Evangelia and you as the audience the case. Please feel free to put your questions into the chat. I will moderate these questions then with Evangelia and Michael. So Evangelia, the floor is yours. We are happy that you're here and that you're going to present the case.
So thank you very much. It's my honor to present a case about the unknown diagnostic tool of MRD in pediatric AML. So we start. So I don't have any conflicts to declare, and we will start with our first case. So I will talk about a 15-year-old male who was diagnosed in June 2021 with a de novo AML M5 and had a CNS involvement. About the genetics, he had a detection of translocation 1119 and a normal karyotype. No other comorbidities were mentioned, and the family history was negative. So in order to start with a diagnosis of AML, which are the milestones? So as I have already told you, we start with morphology. So we have a monoblastic leukemia, AML M5, according to the FAB classification. And then in order to secure our diagnosis, we need the flow cytometry so that we can define the population of the leukemic blasts with specific antibodies that are expressed on the surface. And then we can have a secure diagnosis of AML. That's for the first line diagnosis. And then in order to be able to classify further the myeloid leukemia, we need the karyotype. In our case, we had a normal karyotype, but it is really crucial for AML as a complex karyotype relates and leads to a high-risk stratification. And then we have also the genetics that play a really crucial role, not only in AML, but in all the malignancies nowadays. So we had, in our case, the stratification, as you can see, I have used a table of the risk criteria, and as we don't have any kind of standard risk group criteria or high risk group criteria, then we stratified our patients.
You have to say that Martin has to click on the next slide.
I'm so sorry. So
please don't forget to tell Martin.
We talked about the morphology, so we have to do one click, and then the second click is for flow cytometry, so that we can see the cycles that are popping up. Do you see it?
Yeah,
Martin, please
you can see the table now.
Okay, and now we have
the next one. It's already the next one, Evangelia.
Okay.
It's with the genetics.
Yeah, so we have the table with the green box and the red box. So it's the standard risk and the high risk criteria. And then we click once more and we can see the intermediate risk group. You can see that, right?
Yes.
So our patient did not have any kind of standard or high risk criteria. That's why he was stratified for the intermediate risk group. And then we go to the next slide, and we can see that he received an intermediate risk therapy from June 2021 to April 2022. And as he was CNS positive, then he had also a cranial irradiation from December to January 2022. And then we go further, and you can see a cycle in the MRD in peripheral blood every 4 weeks that is going to be conducted for 1 year after the end of an intensive chemotherapy. We go further, and now we can see the first question. So which are the methods that are part of the diagnosis of AML? Are we talking about morphology and karyotype, about morphology, genetics, and karyotype, or do we need morphology, flow cytometry, genetics, and karyotype? And now I will have your answers.
Give me a second, Evangelia, because there are lots of people in the audience. So
okay.
Shall we comment already on that, Andishe, or
yes, you
later
can already comment. Now you can already comment.
Okay. So Evangelia, would you like to comment what we see? There is 91% say it's from morphology, flow cytometry, genetics, RNA, NGS, and karyotype. But still 9% say it's morphology, genetics, and karyotype. No flow cytometry. I'd like to have you comment. Maybe, I don't know, it's possible in the chat, but or otherwise, why do you think flow cytometry is not? Because it's actually it's an interesting discussion, because it's correct that morphology is a mainstay of diagnostics, and sometimes in particular in AML, it might be said it's not necessary to do flow cytometry. Evangelia, you really alluded to the fact that it's flow cytometry somehow describes the blast population even as a securing the diagnosis, but morphology is really still a mainstay to describe. But for which details will we always need flow cytometry? Is somebody would like to comment on that, or is that possible to comment? I don't know, Andishe, or should we just proceed and explain?
I think we can proceed and explain, because I don't see any comments and
Okay.
questions in the chat.
I'd like to comment because flow cytometry is one of the mainstays of my interest. It's definitely so that we need flow cytometry to describe the megakaryocytic leukemia, because this leukemia is defined by flow cytometry only. There are hints from morphology, but the expression of certain markers like CD41 or 61 or 42 is actually making the diagnosis of M7 FAB. And this is why flow cytometry is not only something used in addition to morphology to make diagnosis more clear and more sure, but it's really necessary for the eventual assessment of differentiation. So this is why those who included flow cytometry, the 91%, were correct.
Okay, thank you, Martin.
Evangelia, please.
Then Evangelia, continue, please, with the next slide.
Thank you for the comment. So we go on with the next slide, and our case, so the patient came to the outpatient clinic or in our hospital in April 2022. And then we conducted the MRD marker analysis, as it was shown by the diagram before, every 4 weeks. And we have detected the translocation 1119, unfortunately, in April. And then we also, now we have to go on so that you can see the two figures of this slide. And as you can see, we had a detection not only in peripheral blood, but also in the bone marrow. And now we go further, because with this detection of MRD through qPCR, we could diagnose a molecular relapse in this case. It's really important to say that in this figure before, so we have to go back to the slide, we have a relativation of its upcoming analysis depended on our first measurement. So that's the way that we analyze our samples. And then after the detection of the molecular relapse, we had the inclusion of this patient in the AMORE study 2017. Are you able to see also the diagram? So this study was an international multi-center open label phase 2 study for molecular relapses, and we examined the action and the response to azacitidine after a couple of samples, so that we could have a stable MRD or a reduction of MRD levels, and then go farther with the transplantation for these patients without unnecessary toxicities. Then we go further to our next slide, when you can see the overview of the MRD analysis that we have done during the treatment with azacitidine after the first cycle, the second and the third one, and the last one was in October of that year. And then we also check the literature, because we have to admit that we have really many subgroups of different MRD markers in pediatric AML. And then we saw that there was also an expression in other cells documented and published by another group. So we decided to examine the T cells for this translocation. And then we go farther, and you can see this line for the expression of the fusion in T cells. You can see the blue line, right? So that's only a percentage. So around 50%, we could say, of the fusion level, that the MRD level that we could detect in total. So we have now come to our second question, and it is, how should be MRD evaluated? Are we talking about MRD positivity that is equal to relapse? Do we have to think that is really the importance of MRD kinetics for a diagnosis of relapse? Or MRD signals are are detected only in leukemic blasts? What do you think?
Twenty-two of nearly 40 people have already voted. So let's see what the other
Okay.
thinks. 65%. We can wait a little bit more. But there's a clear trend.
There's
Okay,
not more coming, right?
Yeah.
Yeah.
Okay.
So Michael, would you like Evangelia to comment on the answers?
So you have to tell me the answers, and then I can comment them.
Yeah. Can you show it, Martin? Yes. 91% voted for importance of MRD kinetics for diagnosis of relapse. 9% MRD signals are only detected in leukemic blasts. Your first answer, 0. MRD positivity
Okay,
equal to
so
relapse.
we have also this almost 9%, like the first question, that is a little bit disorientated. So it's really important to say that we had a detection in the normal T cells. So what we have to evaluate is how is the MRD level is developing. Do we have an increase? Do we have a reduction? Do we have an expression in other cells too?
So this is a very crucial point you are making, Evangelia, because we have seen several occasions where there is a very low grade positivity which does not develop to full-blown leukemia. And this relates to certain kind of subset genetics, for example. We know, for example, in standard risk AML like translocation 821, that MRD might be positive very long term also after end of intensive therapy, and that does not correlate, this positivity does not correlate to impending relapse. And this is something which is an enigma still, because nobody really knows in which type of cells this positivity can be found. It may be in mature cells, it may be even in something which is called pre-leukemic cells, but definitely it depends on a good control of the kinetics. If there is increasing positivity found, this is usually a hallmark of really a molecular relapse, which will finally end in an overt relapse. And to that extent, this kind of intervention with low dose azacitidine, for example, is a current trend. What to do and in order to avoid intensive therapy. Definitely, MRD signals can also be in AML specifically, can be in what we would call not blasts. So blasts relates to really immature reduplicating cells. So not necessarily these PCR signals always are in such immature aggressive cells. It can be even in cells like mast cells or basophils. So that has to be known and to be thought of. And this is why also the MRD kinetics are so important in AML specifically. And we are talking about AML. The situation is completely different in ALL, where there is less maturing cells, less stem cell closeness, like in AML. So please do not mix up this information to the situation in ALL. This is something which is a typical situation for AML, and it's also different in different subtypes of AML. Evangelia, maybe you want to comment.
One last comment, because you talked about the core binding factor leukemias that are most of the times positive at the end of the intensive chemotherapy, and that is well known, but we have to check for the kinetics of MRD. But on the other hand, on the other side, we have the MLL rearrangement AMLs, which are most of the time the high-risk AMLs that are really developing to a rapid relapse at the most times, as soon as their MRD level is detected.
Yeah. So this was I would like to say this is a real rare case of situation where you find in T cells, you find this MLL rearrangement. This is the unusual of the unusual situation. But it's very important to understand that we always learn more and more, and there is with all these very sensitive technologies nowadays, this is why also you said this is the not well understood diagnostic tool to some extent. So this is why I like this case very much, because it's really special.
Thank you, Michael.
So now
I want you to continue.
Yeah, so we go further with the next slide. But we did the stem cell transplantation, and then if we click, then you can see that we have the therapy, and with the next click, you can see that the level of the MRD after the transplantation was almost not detectable. That means that in this case, it didn't really play a role if it was in the T cells or in the blast that we had, but we could eliminate this residual disease, and we could have a patient that was in remission. Unfortunately, every stem cell transplantation, and we go to our next slide, we have also the complications that are really often related with this therapy. And in our patient at day 31, we had a catheter infection and the detection of Staphylococcus epidermidis. The patient was treated with Dworzak as an antibiotic therapy, but this bacterium was resistant to the therapy, so that's why we changed the therapy to meropenem and vancomycin. And then we go further and we see that on day 36, our patient developed, unfortunately, a fever, tachycardia, pulmonary distress, and he had also a reduction of the renal function. He was anuric and he had a renal failure. So we were talking about a severe infection syndrome. And of course, and we did everything of the side of the diagnostics in order to find out what was the reason that this patient was really deteriorating so quickly. And we also conducted the NGS panel, a PCR for different bacteria, but everything was negative. And then, as you can see, we had the only result that was positive was the Toxoplasma gondii, and that could be, but we're not pretty sure if that was the reason that unfortunately led to the death of our patient. And then I end with the third question: how to prevent the transplant-related mortality? Do we have to reduce toxicity by detection of molecular relapse and early intervention to the therapy? Do we have to standardize the screening for microbiology and virology in order to start with antibiotics and antiviral therapy early? Do we have to use prompt antibiotics and antimycotic as prophylaxis? Do we have to do the treatment only by experienced intensive care staff, or do we need all the above?
Okay, Evangelia, the answers are coming in.
So maybe I can make a comment. So we were really happy and proud as team that we could have a reduction of MRD for this patient, and we thought that everything was fine. And then this severe complication that was unfortunately lethally was really devastating for the whole team. But sometimes it's not enough to do the best that we can. We're not able to save everyone.
Evangelia, I can tell you that almost 80% of the answers are all of the above. So the last answer that you offered, a few clicked the previous answers. So what is the correct answer, Evangelia?
It's all of the above. So we have to combine everything in order to achieve a reduction or to prevent the transplant-related mortality in our patients.
I mean, the experienced intensive care staff is definitely something which can be, in a broader sense, intensive care staff. So we think that transplantation units, they have also kind of intensive care staff, but definitely it's experience is the most important word in this. Definitely not every patient needs to be cared before he gets severe complications, needs to be treated on an ICU. But the intensive, the transplantation unit usually is also very experienced and semi-intensive
Intermediate
ward.
care unit.
I think intermediate care, yeah, could be said, yeah. But definitely what you show well is actually we always have to think what is the situation in the case of molecular relapse. Because this case really shows you did not detect by morphology, you did not detect real blast relapse. And this is a very special situation. Based on molecular means, you make a diagnosis. You make a diagnosis of treatment necessity and you indicate transplantation. And the big question is actually, is this correct? Is this what you find really placing the need of the patient to go in to enter transplantation? On the one hand, You want to avoid TIM by avoiding too intensive chemotherapy. So by waiting for an overt relapse, you would say, okay, now we need many drugs and intensive drugs and reinduction therapy and maybe antibody therapy, and placing the patient again into a severe toxicity profile of treatment. On the one hand, okay, morphology relapse is something where, okay, say it's clear, it's for sure, and you have to do something because there is no other way out of this. But with the molecular relapse, the situation is really different. You need to be sure that what you are seeing, what you are detecting really is a danger for the patient. And this makes the situation so delicate, really to indicate it. So pretty sure that KMT2A rearrangement, detection of KMT2A rearrangement is a hallmark of overt relapse. So all we know for the time being is actually that this is the case. This is usually always the case. Not speaking about core binding factor, we talked about the dynamics which are relevant, but in a KMT2A, usually if you find PCR positivity, this is a hallmark of relapse. So it was correct to go that way, but you always get puzzled if you then have a patient dying for a leukemia which you have treated, you haven't seen. So this is a real making us in our mind as clinicians. It's a new era we are entering, thinking we do things better. But the other hand, we have a patient who dies, and we are thrown back on ourselves and thinking whether we have done right. But all we know for the moment, this was correct to go that way. But again, we need to be very careful in interpretation of what we see by new diagnostic means. Do another test, do a test maybe in a reference laboratory. So I wouldn't dare to believe any laboratory outside somewhere detecting something to say, okay, we can believe that this is correct. You might think of flow cytometry, you might think of genetic methodology. So we really have to do that very careful, very standardized, quality controlled, but because this is the implications for the patients are massive. Because for the moment, there is no relapse of AML where we think we can survive, save the survival of the patient without transplantation. This is the point. If you say, okay, we are only putting him on some kind of chemotherapy, it's maybe less dangerous than indicating a transplantation.
Okay, thank you, Michael, for all your comments. I just look at the chat. At the moment, I cannot see any question. May I ask perhaps a question? Michael, do you think it is really the right way to go to transplant the patient with AML in a relapse situation without having given before what we have done for years, at least 2 chemotherapy blocks to have a deep remission? Or do you say this is not needed if it's only at the MRD level, chemotherapy is not needed at all, we go directly into the conditioning?
No, I think it all relates to it's a good question, Andishe, and practically I can only comment what is nowadays thought. Nowadays, there is a lot of thinking that it relates to leukemic burden. And leukemic burden has to be low to a certain extent, which means you shouldn't see blasts by morphology. So this means that what way you gain this knowledge, whether you need massive chemotherapy to reach that because the relapse was full blown and you need several blocks of chemotherapy. Usually these will be 2, for example, with an overt relapse at least, to lower the leukemic burden. Or you enter with molecular situations still, and you try to keep it at a low level, unseen by morphology. So nobody knows. But I would definitely No, I would definitely say a word of caution, because we know that a single test or a bone marrow test not always shows what's really going on in the body, because we know some leukemias trend to be more sticky to some tissues. You may have more in the liver, or more in the spleen, or you may have, as we know, some appear as localized extramedullary relapse. We know, for example, that at least two rearranged leukemia uh, trends to have low counts, but still have accumulation somewhere else in the body. So what I mean is, and I'm alluding to, is testing only blood or testing only bone marrow may not in total be a good quantification possibility of the entire tumor load and leukemic cell load. So we need to check what is the size of the organs. Is there any extramedullary infiltration? Because even if the counts are low in marrow or blood, we need also to consider, is there extramedullary relapse, which we also might need to treat. It can be in ovaries, it can be in any sanctuaries which we don't overlook with simple or mere bone marrow testing. So that has always to be considered. Yeah.
Thank you, Michael. I have a question now from Anna Eichinger. We just met each other in Milano. Hello, Anna. She's asking you, Evangelia. Did you have a positive serology screening for toxoplasma before going into the transplant? For example, we in Vienna, we always test for toxoplasmosis serology. And did you have this? And did you change or add therapeutics? I guess she means antibiotics after the positive PCR finding.
So yeah, so we do a test for toxoplasmosis for all the patients before they go to transplant. So it's a standard in our unit. We had an IgM negative result and an IgG positive result, but we didn't have any other option at that moment. And the positive PCR result was detected after the patient was dead. So it was only discussed in our unit afterwards. Yeah, but the last test that was 1 week earlier was negative. And we conduct that once per week. Now we started doing that twice per week.
In case of seropositivity.
Yeah.
Yeah.
For this group of patients, we do that twice a week.
Yeah. Had the patient Eusaprim or cotrimoxazole in advance of the, because actually, as you said, this patient was from Ukraine, and the patient came already after end of treatment, of intensive treatment, and you found the patient to have this molecular relapse later on. So maybe he was already off any cotrimoxazole prophylaxis. I don't know. How was that?
So we started with azacitidine cotrimoxazole prophylaxis because we knew he was going to be transplanted.
Yeah.
Okay, thank you. So I think
You would think that this is also a prophylaxis for aggravation of toxoplasmosis in a way. Yeah.
Yeah, the last question comes from Jess Morgan from UK. I think it goes to both of you. Is there any evidence that routine surveillance of MRD after treatment finishes for AML improves survival for these patients? Are there any randomized controlled trials to prove this? I think this is the obvious question. Michael, Evangelia.
No. There will be first publications out in the next year, I think, but there is no randomized trial. No. This is just, let's say, on its way. But you are correct. It's not a standard in all protocols or in all environments. This is something which is thought, which might help, but not clear enough. I mean, there is Evangelia has, maybe you provide a nice list of literature. There is this from the group in Denmark who tried this first from the Oman study. They have shown that sometimes you are too late because the KMT2A, they are very rapidly leading to relapse. For other like CBF leukemias, it's so that the kinetics of molecular relapse are slower, and it might happen that those can be better treated by with low dose, but they have per se a very good or a better outcome, not very good, but a better outcome, about 70% survival after a first relapse. So it will be hard to prove. Many patients would be needed to prove that this screening is helpful for them. So this is really something which, let's say, came from this is a phase 1/2 trial actually, where this was detected in this patient. Am I correct, Evangelia? It's an early trial, this Attarbaschi trial.
Yeah, that's a phase 2 trial, and unfortunately,
Yeah.
it's good for the patients, but we have so low numbers of patients that were included. So it was less than 10 per year in Germany, and we have 120 new diagnoses per year in pediatric AML. So that it is not possible to do a randomized trial with 2 arms because in order to get the number of patients that you need to have a significant, relevant result, you have to wait maybe 30 years. And that's not possible. So that's
or include the colleagues from Britain, from UK into this trial and endeavor.
Okay, I think we are done. So thanks a lot to you, Evangelia, for presenting this very exceptional case, and for Michael for sharing his expertise in AML with us. I think we had nearly 45 people in the audience. Martin, I cannot remember to have so many people at one of our ERN PETCAN webinars. I think the title that you have chosen, Evangelia, together with Michael, attracted a lot of people. So perhaps, Evangelia, you just briefly give the take-home messages, and then we have to wrap up and say goodbye for today.
Okay, so about the take-home messages, we talked about the different relapse kinetics of MRD in pediatric AML and the MRD persistence after therapy for the core binding factor leukemias with translocation 821 and inversion 16. And we talked also about the rapid relapses in subgroups of MLR rearrangement AMLs. Then we talked about that we don't have a standard therapy for molecular relapse that's not yet defined, and that's why we have to do everything to avoid the transplant-related mortality at stem cell transplantation. And we have to get there through an early diagnosis and a lower intensity of treatment. That's why we have to refine the stratification and response assessment and avoid any stem cell transplantation that is not indicated. We have always to consider that on the other side, we have also the complication of this treatment. And last, we talked about optimization of viral, and we have always to think about optimization of viral and microbiological screening and prophylaxis during the stem cell transplantation. So thank you very much. It was an honor cooperating and working with you for this case reports. And I'm really happy that, and I hope that you have learned really much this last hour with us.
Thanks, Evangelia. Thanks, Magda. I can see people uploading in the chat. So they really enjoyed the session that the two of you established for us today. So I wish all a good evening and hope to see you at one of the next year-end PET-CAN webinars. Ciao.
Ciao. Thank you. Bye bye. Ciao, ciao, Evangelia.